originally from the UK, as you will learn as soon as she's but she did her PhD in Belgium, right? She also transitioned to the Karolinska Institute, and now last 2 years, right?
Almost, yeah.
Almost, yes. She has been a data manager and also a postdoctoral researcher in genetics in the AMIPAD consortium. In Amsterdam, she's in the group of Frederick Barco. And I really want to invite her here today because she will talk us about genetics. Not so much, never inviting us for our invites lately. And also I think it's an area where we really can do more work than the one that we actually do. So we will learn a bit about the amyloid polygenic, right?
Yeah.
Sure.
Thank you. Thanks everyone for being here today and for the invitation as well. I hope to tell you a little bit about some of the recent genetic work within AMIPAD, and then the real focus is polygenic risk scores. And all because it's AMIPAD is in the preclinical phase of AD. So I think all of you work in Alzheimer's then, right? So we all know that the road to Alzheimer's is a long one, where we characterize individuals once they've had a clinical diagnosis. But we know that this is too late in the disease progression, where changes in the brain, such as the accumulation of amyloid and tau, occur in the preclinical phase, where individuals are still cognitively healthy prior to the presentation of mild cognitive impairment prior to full-blown dementia. Historically, a dementia diagnosis was given after the emergence of clinical symptoms, but we know that that's too late in the disease progression. And I would say this biomarker era between 2010 and 2020 has really allowed us to characterize the preclinical phase. And this has mainly involved amyloid and tau PET imaging, but has more recently progressed into fluid biomarkers such as CSF or tau. But we've sort of moved again a bit further into this precision medicine era. So it's not just about early detection anymore, because we've proven that we can detect, for example, amyloid and tau accumulation in the preclinical phase, but more about who we should screen and how can we best stratify that risk. So we need scalable and non-invasive biomarkers. Oh, something's gone wrong with my presentation, so you can ignore the prettiness of it, if that happens throughout the rest of it. But we need to have scalable and non-invasive biomarkers to enable early identification for early intervention, because that's when treatment is most likely to have the most benefit to our patients. I've had a consistent theme since my PhD of neuroimaging, and in particular using amyloid PET imaging. So that's a very minor aspect of my presentation, because the focus is on how we can best predict the change in amyloid rather than amyloid being the main focus. My main focus has been genetics, or more of an omics view of things. So for those of you who are unfamiliar with a genome-wide association study, we compare the genomes of AD patients compared to controls in order to find variants that increase or decrease risk of developing the disease. And the most common form of looking at that is using a Manhattan plot, which you can see here on the right from the Belenguez study. I was talking about it at lunch. This identified 75 loci to be associated with Alzheimer's. And all of these GWAS studies, I think in the last 10 years or so, have kind of exploded compared to before. So initial twin studies suggested a heritability of AD of around 60 to 80%. But now we find a lot more loci to be involved with AD, which you can see here from all these peaks, which reflect individual genes and variants. And then with those, we can perform biological enrichment. So to see what kind of biological pathways are maybe involved with the increased or decreased risk. And pretty consistently, we find enrichment for things like lipid pathways, which is maybe to be expected with the influence that we know ApoE has, or ApoE4, as well as changes in the immune response and metabolism. And all of this together really highlights the complexity and heterogeneity of AD. And from a genetics perspective, we call AD a complex disease. So I think this is really reflective of that. If we zoom in a bit more on the genetic variants themselves, I'm sure you all know about the APP, PSEN1 and PSEN2 genes, for which if you carry a highly penetrant mutation, you develop familial autosomal dominant AD. That was my work focus at the Karolinska Institute, but not anymore. So we're just going to focus on everything else. Um, you all, I'm sure, are then aware that ApoE4 is the strongest genetic risk factor that we have for sporadic AD, where E4 heterozygotes are 3 to 4-fold at increased risk of AD, and homozygotes 8 to 12-fold increased risk. But not all AD patients carry it, so it's not necessary nor sufficient to develop the disease, but quite a large proportion do carry at least one allele. And carrying ApoE4 is involved then, which is what I was looking at more or less in my PhD, was higher amyloid burden, a faster rate of amyloid accumulation, and a younger age of symptom onset. But if we shift our focus away from ApoE, you can see that there are lots of other variants, especially in this area here. So along the x-axis, you have the minor allele frequency, which is the frequency of this to appear in the global population. And then I think it says odds ratio there. So then the effect size. And you can see that there are lots in this part, especially that there are lots of genetic variants that are, I would say this is quite frequent in the population, but with a very low effect size. So in isolation, they have a very isolated predictive ability by themselves, which is then where polygenic risk scores come in. So for those of you who don't know what a polygenic risk score is, it's an aggregated risk score, basically. So you can combine the effect of all of your individual SNPs that you want to look at. So let's say genome-wide. And you can combine these into an individual score. And that's then a single estimate of an individual's risk to developing a disease. So in our case, Alzheimer's. And you can see that the higher you are on the PRS percentile or the higher your risk score, the higher your risk of developing a particular disease. And the nice part about polygenic risk scores is that they are non-invasive and cost-effective. So it's more likely that they can be rolled out on a population-wide. And in the field of breast cancer, polygenic risk scores have already been proven very useful for risk stratification. So I think things like that really show the potential for them in our field of AD. But we still require some improvements, especially in biological specificity and then clinical interpretability. So based on that, over the last, I think, 5 years or so, especially at the end of my PhD and over my KI into Amsterdam, we've had three main overall aims. And the first is then to harmonize genotype array data from across different European cohorts. We want to then use these scores, we then want to use these data, to compute polygenic risk scores and then investigate the relationship of these scores with global amyloid burden. We've used the AMIPAD prognostic and natural history study for this. So this is a pan-European cohort of preclinical individuals where everyone was already enrolled in an established study. So you can see that there's 32 sites across 10 countries, and these are the cohorts down here. And everyone had to be older than 50 to be included, with an MMSE of at least 27 and a CDR of 0 or 0.5. And everyone as part of the AMIPAD study was scanned for amyloid, so either florbetaben or flutometamol. And you can appreciate that the majority of individuals are amyloid negative, with some then in the gray zone and some who are classified as positive. Of all of these individuals within AMIPAD, a subset had genotyping data available. So we had EPAD, which is also another European-wide study, as well as EMIF-AD, which is also pan-European, but we had the twin subset from the Netherlands, so a bit more of a focused subcohort. We also had Alpha and Fasebi, who are both from Spain, and FPAC, which is from Belgium. This is the overall schematic of the pipeline from raw genetic data, like raw array data, into the final polygenic risk scores. And this is broken up into what I think are three main segments. So we first have the pre-imputation procedures, followed by the imputation and post-imputation QC, and then the PRS calculations. And this Stream PRS tool is used to calculate these scores, which is now available as a tool on GitHub. So that's quite nice. And that was made by my old PhD supervisor's lab group. So I definitely advocate for its use. But we'll go through each of the three segments individually. So we begin with the pre-imputation procedures. So I acquired the raw genotype array data from every cohort, and all the QC actually throughout the whole process is performed using Plink 1.9. And all AMIPAD cohorts had a genome build of 37. So we perform things like removing duplicate SNPs or removing SNPs with a low call rate. So it's we're looking at the amount of missingness. So maybe there's a particular SNP that's missing across almost everyone, or there's an individual with a lot of missing SNPs. So then we remove those individuals or SNPs. We apply a minor allele frequency of at least 1%. And then there are some other steps as well performed. And then we perform a population stratification, and that's using phase 3000 genomes to remove any ethnic outliers. When we look at the PCA plot, you can see the 1000 genomes individuals are in gray, and then each individual AMIPAD data set has a different color. And you can see that even though our cohorts do come from either different countries or different places within the same country, they are largely overlapping. So we deemed that these individuals do have a genetic profile similar to each other and the wider European population. We then perform the imputation and post-imputation procedures. So first of all, we lifted the genome build from 37 to 38 because you can only impute in genome build 38. And we used the TopMed imputation server. After the imputation, we performed a filtering using an imputation information score of 0.7 and again a minor allele frequency of 1%. And then we merged each of the AMIPAD parent cohorts to have one large data set. And for this, we used the merge mode 2 function in Plink. So you take two cohorts, let's say FPAC and FASEBI, you extract the overlapping SNPs between both cohorts and merge them together. And if there are any duplicate IDs, it always takes the data from the second data set. However, from doing this, I know that there are no duplicate IDs between the different cohorts, but there were duplicate samples because EPAD is a pan-European cohort. So I know, for example, FPAC participants also participated in EPAD, but we removed the EPAD ID because all parent cohorts gave their data rather than EPAD giving the data. We also merged last with the twins, so the EMIF 60++ sample, because we wanted to retain all twin pairs rather than remove anyone at this stage. And then we performed some final sanity checks, so similar steps to the original QC at the very beginning. We then performed the PRS computation. So for this, we did scores with and without the ApoE region, and we calculated scores based on 3 GWAS summary statistics as the base file. So the first was the Kunkel 2019 AD susceptibility GWAS, so that's a case control design. And then we took the Janssen 2022 CSF based summary statistics. So those are for levels of p-tau 181 and A beta 42. We calculated PRS based on multiple SNP inclusion thresholds, which ranged from genome-wide significant to 1. But for the purpose of this study, we just chose the 3 most popular thresholds for SNP inclusion. So that's genome-wide significant at 5 times 10 to the minus 8, genome-wide suggestive, which is 1 times 10 to the minus 5, and 0.1. And all of our scores were computed using Precise. After the computation, we corrected all scores for the first 5 genetic principal components, and those are extracted from the population stratification. And then we standardized our scores against the European individuals from 1000 genomes. All of our stats were performed in R with bond for only correction, and before any analysis were performed, we applied a threshold for the pi hat of more than zero point 0.2 to remove any related individuals, which basically meant removing one of the twin pairs. And that was all based on data availability. So maybe one of the twin pairs didn't have a PET scan or something like that. So we did it based on data. And then we looked at a use of these harmonized genetic data, so their characteristics. And for this, we looked at their density plots. There are also loads more results than what I'm going to show, but I'm just going to pick out the main ones to show you today. There were 867 participants with just over 6.3 million SNPs for PRS computation. And we can see, so each different panel is a different score. So the top row is scores including the ApoE region. The bottom are scores excluding the ApoE region. We have CSF amyloids, p-tau, and then Kunkel, and every different color is a different cohort. But we can see that the PRS between cohorts are largely overlapping, and I think that's really important for the validity of cross-cohort genetic analysis. But it also helps strengthen the generalizability of our AMIPAD findings to the wider European population. And on that, I think an important factor that we implemented here was that we removed intra-cohort standardization by standardizing against 1,000 genomes, because it's becoming much more common to do something like that. But at least maybe 5 years ago, it was quite common to do intra-cohort standardization, and then it's really hard to do replicability across different centers. So based on that, we deemed the harmonization successful. We then looked at an application of PRS. So this was their stratification in a clinical context. We split the PRS into low, medium, and high risk tertiles, and we looked at centiloid burden pairwise. And then we did some logistic regressions using the PRS risk groups to predict high versus low amyloid. Yeah?
Okay. So do you weight the PRS by the odds ratio, or you just add them up?
No, it's odds ratio.
You wait for the odds
Yeah,
ratio.
and the p-value. The p-value and the odds
p-value as well.
Yeah, it's based on both.
Okay.
Yeah, the values for those are taken from the summary statistics based on whatever SNPs an individual for themselves has.
Okay.
High versus low amyloid. For this, we used a centiloid threshold of more than 30 to be high amyloid. And then it was based on 3 contrasts of PRS risk. So amyloid burden, and this is just an example. So on the y-axis, you have the centiloid, and then on the x-axis, the 3 PRS risk groups. And we see that amyloid burden was significantly different between all low, medium, and high risk tertiles for scores that included the ApoE region, except for PRS Kunkel at 0.1. And amyloid burden was not significantly different between risk tertiles for any of the PRS, excluding ApoE, except for PRS amyloid. And in the cases where we did see significance, individuals in the high risk group had significantly higher burden compared to the medium and low risk groups. When we dichotomized the amyloid into high and low, we saw 8 models significant for high versus low risk, 2 for high versus medium, and 3 for medium versus low. And the highest odds ratio came from having this CSF amyloid at PT as 1 times 10 to the minus 5, including the ApoE region, which gave an odds ratio of 6.2. But you can see that the genome-wide significance score for the same build, so at 5 times 10 to the minus 8, was really similar. And I think this odds ratio was 5.6, so not too dissimilar from what we see with 1 times 10 to the minus 5. There are lots of other results that I didn't show, but in almost all cases, PRS amyloid outperformed all of the other scores. So we also did some linear regressions, and you can see here the circle points are that for PRS amyloid, and you can see the adjusted R squared is higher here. And we can see the standardized beta as well. So yes, a lot of them are significant, but almost in all cases, CSF amyloid was better performing, and that was at genome-wide significant and genome-wide suggestive. So we concluded that PRS derived from CSF A beta 42 GWAS summary statistics contain more relevant genetic variants, at least for predicting early amyloid or high early amyloid burden. And this shows that we should maybe go beyond the traditional case control design when we look at different GWAS. So this complements published literature, validates the use of using summary stats beyond AD susceptibility, as well as highlights the potential for targeted genetic profiling. Some other results that are also of interest is that PRS amyloid no ApoE and PRS tau no ApoE at 0.1 were also significantly associated with amyloid burden, which does suggest that there are maybe some non-ApoE4 pathways or variants that are also contributing early in the disease progression. And this was kind of solidified a bit more by the fact that PRS tau no ApoE at 0.1 also remained significant in a series of regressions when we included an interaction term with this score with ApoE4 status. So we believe that this indicates that this particular PRS independently contributes to amyloid burden. But it still feels like we're missing something. So we know that clinical AD is the endpoint where we see clinical symptoms, but this is really far removed from the genetic signal. So we know that we have genetic variants which influence pathology, which results in having measurable molecular and cellular changes, which results in seeing a clinical phenotype. But each of these individual steps adds noise. And we know that AD is heterogeneous. There's different trajectories with different people. There's comorbidities and co-pathology influences as well, cognitive reserve or resilience. So how can we refine our scores a bit more that's not based if we're just looking at this clinical endpoint? We started to do it in the results I just showed you, so looking at CSF amyloid and tau scores, but I think this could be done more. So we shifted our hypothesis a bit in looking at PRS based on more intermediate biomarker phenotypes. And we think that these biomarker phenotype scores, especially based on the CSF amyloid ones we just looked at, that these should outperform the traditional AD susceptibility ones because they're probably more likely closer to the underlying biological pathways that are influencing the pathology that we observe. It also means if we do find any significance with any other biomarker-based scores, that those should inform us about maybe how important these phenotypes are for the clinical presentation. So we calculated even more PRS. So you can see these here, and these are based more than on these intermediate phenotypes. So we again used AD susceptibility and CSF A beta and p-tau 181. And for all of the scores now as part of this follow-up study are all used at either 1 × 10⁻⁵, so genome-wide suggestive threshold for SNP inclusion, or based on a SNP list from the PRS catalog, because those are what were recommended in the original study. So then we looked at some other PRS reflecting broader domains relevant to neurodegeneration. So BRAC for tau staging and CERAD for amyloid staging, as well as then some general aging domains. So cerebrovascular integrity and systemic metabolism using SNP lists, and then inflammation, brain age, and social frailty using 1 × 10⁻⁵. So we wanted to look at whether we could identify some biologically distinct subgroups within the AMIPAD cohort. So this follow-up study uses the same individuals as the first study, uses the same harmonized genetic data set and the exact same stream PRS pipeline, just different summary statistics as the different base files. You can see the strong effect of ApoE in some of these scores. So the darker the data point, the more E4 alleles an individual carries. Again, in the top panel, you see scores including ApoE and excluding ApoE on the bottom. And you can see that the less E4 allele carriers have lower risk, at least for the majority of these scores. And you can see that this effect is lost when the ApoE region is excluded, which shows the strong influence that ApoE has on this on these biomarker phenotypes. So then we looked at the SNP overlap between the different scores, and there was a limited SNP overlap. So This was obviously not true for the pairs of PRS. So if you take AD susceptibility with and without the ApoE region, there's obviously a very high overlap in SNPs. But if you take AD susceptibility and metabolism, there's almost no overlap. And you can see the very small number of SNPs compared to the thousands that are in some of these scores. So this suggests that we are capturing a distinct aspect of genetic liability. So when these scores are not reflecting the same underlying signal, they're reflecting individually something different. We again performed some group comparisons. So we looked at amyloid positive versus negative using a Sensiloid threshold of 21, ApoE4 carriers and non-carriers, and males versus females. We then performed some linear regressions, and this time we looked at Sensiloid as the outcome or some cognitive outcomes. Of course, PRS was our main predictor, and then our standard covariates of age, sex, and education. And for the cognitive outcomes, we first looked at global cognition with MMSE, but then also memory domains, because we know that memory is one of the earliest to change. So for this, within within Amipad, we had immediate and delayed recall, recognition, and visual memory. But because this is a large harmonized cohort, each of the individual tests are harmonized intra-cohort. So we use Z scores for the analysis. And then we perform pairwise likelihood ratio tests with Bonferroni correction from our regression comparisons. Males and females did not have any differences, so I'm not going to talk about that anymore. But we first looked at amyloid positive versus negative, and we did find some distinct architectures between these other groups. So you can see that amyloid positive individuals had higher scores for these AD, I would say more AD based PRS. So AD susceptibility, BRAC, SERAD, CSF amyloid, and CSF p-tau. And ApoE4 carriers also had significantly higher risk for these scores, as well as inflammation, excluding the ApoE region. And I wasn't expecting this, so I don't really know how to explain it, but ApoE4 carriers had a significantly lower risk for brain age, excluding the ApoE region. So I need to look at what SNPs are involved in that score to see what that really means. But E4 carriers having a lower risk for something was not something that I expected to see. We then looked at the predictive value for PRS for amyloid PET, and we see that again, PRS CSF amyloid was the strongest individual predictor, and this significantly outperformed all the other PRS except for SERAD and AD susceptibility. So this is SERAD and this is AD susceptibility, and I think you can see that they are pretty similar.
How you measure brain age?
Yeah, I need to check again because I haven't looked at this for a really long time, which is really bad because I should know what these summary statistics are like off the top of my head, and I don't. I need to check. Yeah. Somewhat to be expected. PRS excluding the ApoE region were not significantly associated with amyloid burden after Bonferroni correction. But I looked at whether the PRS, including the ApoE region, maybe outperformed their non-ApoE counterparts. And they did for CSF, amyloid, SERAD, AD susceptibility, BRAC, and p-tau, but not the other ones. We then looked at the predictive value for cognitive performance. And when we first looked at MMSE, the best performing score was PRS SERAD, and this significantly outperformed all other PRS except for CSF amyloid and BRAC. And we see that for some of these, the ApoE region appears to be essential for the significance. So BRAC, CSF amyloid, and p-tau were also significant, and these were also significantly better than their non-ApoE counterparts. When we looked at immediate recall, the best was CSF amyloid, but this didn't outperform any others. So it appears that maybe the ApoE region is not as important for immediate recall. When we looked at recognition, the best score was PRS SERAD, and this significantly outperformed it, very similar to MMSE, CSF amyloid, and BRAC. The others were also significant, and we do see some PRS, including the ApoE region, were significantly better than their non-ApoE counterparts, suggesting again that the ApoE region seems to be important. And again, very similar with visual memory. So the best was CSF amyloid, which outperformed all scores except SERAD. And SERAD, p-tau, BRAC, and AD susceptibility were also significant, as were they compared to their non-ApoE counterparts. So again, ApoE seems to be a very important player here. For delayed recall, there was no significance observed. So overall, we find that the biomarker PRS do consistently outperform the conventional AD susceptibility PRS, and this validates the use of the endophenotype hypothesis, and it does suggest that we are capturing more proximal disease mechanisms. Some early next steps. I did perform some mediation analyses, but this is not complete yet. This is really preliminary still, and also some clustering. So it seems that there's and it's you could kind of see it before when you see. Thanks. How do we know if it's working or not? He can tell. Maybe I can go again. Okay. The AD susceptibility PRS, we saw that amyloid PET was fully explained on MMSE, but I want to repeat all of these with the different cognitive outcomes we have, because this was done as a preliminary analysis, but I think to see with the other cognitive outcomes will be a bit more interesting than just MMSE. But the most important thing, I think, is how do we translate these findings into clinical practice? So we could suggest a hierarchical screening pipeline. So we want to detect who is going to go most down this path as early as possible before any of this happens. And I think one of the most easiest options is to do some sort of genetic pre-screen, mostly because it's non-invasive, scalable, and cheap. So it's much easier to roll something like if you take 100 people for a clinical trial and you do a multi-PRS profile, for example, then I think it will help you to reduce your risk population. So you could then do confirmatory biomarker analysis, which is a bit more invasive, but still scalable and still relatively cheap. And I think then we all agree probably that you can do p-tau 217 and the AB to 42/40 ratio before then your final neuroimaging based confirmation of amyloid or tau PET, which is much more invasive and expensive. But I think also this multi-PRS profile, we don't see it in our data right now, but I think if you have more data, maybe more patterns emerge. But maybe you've got some individuals who have high amyloid scores, in which case they're likely to be targeting an anti-amyloid therapy. But maybe you've got a group of individuals who have a high tau score or inflammation, and then you can start to match patients or participants based on their underlying genetics for the biological changes to then a particular treatment once we get to that point where more treatments and a more variety of treatments become available. So some key takeaways are that we've shown that we can harmonize genotype array data from a pan-European within a pan-European cohort, which does seem to be generalizable to the broader European population. We've shown that biomarker-informed PRS tend to outperform conventional AD susceptibility scores, but that these also predict amyloid burden as well as early cognitive differences. And we propose a hierarchical screening pipeline which could help enable scalable precision prevention. The biggest caveat, though, that I haven't mentioned that I'm extremely well aware of is the fact that these results are not generalizable to beyond the European population. Every set of summary statistics we use is built using European ancestry individuals. Amipad is also European ancestry. Anyone who isn't of European ancestry was removed in the QC process. So I think it's extremely important that we move to some cross-ancestry analysis. And this is, I think, one of the biggest problems in AD genetic research, but it is becoming better. There are much more cross-ancestry analysis or genetic studies within different ancestry populations by themselves. So it's slowly getting there, but yeah, I'm very well aware that this is not generalizable, but I think it's still helpful to know. But I think we should look to see if whether the things that we see in European populations are transferable to others. Maybe there are different SNPs with higher minor allele frequency or not, or higher effect size. So I think it's important that we make those comparisons. Oh, otherwise, I have to, of course, thank the AMIPAD Consortium and my old lab group, who I still work with on this in Belgium, and ADDI for our funding, and all of our participants, and all of you for listening.
Okay, thanks, Emma, for the talk. And we are very proud of the discussions we have after seminars. So I would like to invite everybody to participate and ask questions. Two of the usual suspects.
Thank you very much. It's a really, really interesting topic. And we are, as I mentioned to you, we have a lot of data now, and we are going to have a lot of data of genetics and biomarkers. And so I think that from a clinical perspective, the question is how much predictive value adds the PRS to the plasma biomarkers? Did you
Yeah.
this analysis?
No, because we don't have that much plasma biomarker data available. That's the problem. But PRS by themselves, I think, let's say, has a predictive ability of around 12%. I think that could be improved if we can refine the scores a bit more and how they're built. But I think they're good then in that sense for that first stage. But I think to make them better, we do need to combine it with plasma biomarker.
And in your view, what would be the sequence if you're in a clinical context? How would you introduce the patient in a pathway? What things? How would you select the individuals? I mean, just.
I mean, if you're selecting for a clinical trial, then, for example, you have your general recruitment criteria. I would then do a first stage PRS, multi-PRS profile. You could acquire the blood and do the plasma biomarker analysis at the same time, and then use that to decide whether that person is at increased risk enough to then do further testing or whether they're not. But the whole point is to stop the clinical progression, right? And then you need to look when someone is still healthy. The thing with the PRS, I know that it's not as static as maybe we view it, but essentially your genome doesn't change, let's say, as a really simplistic view. Then you could just do it once and then maybe measure over time the plasma biomarker changes. But how realistic that is in real life, I'm not so sure.
So you would use it to modulate the risk of the plasma biomarkers to sort of.
Yeah, I think I would do a primary assessment with a PRS profile. Yes, exactly. But well, then you've got methylation differences. So then that could be another aspect, or maybe some gene expression changes.
Doesn't
But
apply really to the GWAS, right? I'm very ignorant in terms of genetics, so maybe.
well, then in the most simplistic view,
Yeah.
no. So let's just do one blood test when you're young or a saliva test, make your PRS profile, see how it looks,
Yeah,
and then decide what to do depending on how it is.
I mean, obvious advantage against the blood is you can do it. So the plasma biomarker will eventually become positive, but the genetics, I guess you can profile people much earlier. Right?
Yeah.
Yeah, I really try to understand a bit more about how about PRS in general, like technically and conceptually. So I think it's really interesting and really an important way to go forward. The multi PRS, right? The different try to capture different biological pathways. And in this sense, I don't know, you had like 10 different ones, brain age and whatever. And it is my understanding that all these PRS critically depend on the availability of robust summary statistics, right? Which is certainly the case for these AD susceptibility, which include like 20, 30, hundred thousands of individuals. But how is that then for for some of these other metrics? You also mentioned BRAC and SERAT, and this would require autopsy data, I guess. And then also the underlying population, if it's a population-based autopsy cohort, which is even more rare, or I think the genetic associations and the summary statistics may change considerably, not only by the number of the available data per individuals in the cohort, but also in their stage. So if you have like a dementia specific autopsy cohort, may be totally different if you have a population-based cohort where most of the individuals died of other reasons that were not dementia, right?
That is, so the first biggest problem with these different GWAS is the sample size. So let's say the metabolism or brain age one, the number of participants that are in that is much smaller than the Kunkel one. But if you look at the Kunkel 2019, that's also smaller than the Valengues 2022, which is smaller than the Whiteman 2023. Then you have to make a decision. What is the best? And we were kind of talking about it earlier, like what's your primary outcome with what you're looking at? Where do you draw the line anyway? I personally don't like yet the inclusion of AD by proxy cases in these GWAS, which is why I also still stick with the Kunkel 2019. I know that having these by proxy cases increases your sample size, but it's not based on a definitive diagnosis. Neither is really the Kunkel one, because what if there are comorbidities that we didn't know about back then? What if some of the controls are young and they end up getting old enough that they develop the disease? Are they really then a control? So it's quite difficult, but you have to draw the line somewhere.
I think you should explain the
by proxy.
Yeah,
I did wonder that.
people hear that, so.
If you perform a GWAS, you look at patients versus controls, and it's quite often that your control, let's say your control sample size is 500,000, but your AD patient size is 2,000. You want to increase that number to make it higher, to make it more robust, to help you identify more variants. So the inclusion of by proxy cases in the case of Valengues, at least in the Whiteman, is based on having a first-degree parental relative with a definitive diagnosis. So that makes you then a patient in that. I mean, yes, it increases your sample size, but what if they don't go on to develop the disease?
So, I think, I mean, there you have a double problem. The problem of clinical diagnosis.
Also a problem.
Problematic in itself.
No.
Then if you go to by proxy, then it already
it's another layer
duplicates,
of uncertainty.
And so I wonder whether it's really so important to have thousands and thousands of not so well only clinically characterized individuals, or have a smaller number of where you have
very well defined
a biological ground truth.
Yeah, but then if the sample isn't big enough, you really don't have enough power to detect the variance, and that's then a problem. They do. There's actually a new study. It's not published, so I used the A beta 42 and p-tau 181 summary statistics, and the same authors have just had, because I'm a co-author on it, and I just saw the acceptance email last week or something. It's an even bigger study of that with more individuals. I need to read again the methods behind it, because they wouldn't have included by proxy cases, but then I need to see where they found more samples from, because clearly they have a bigger sample size now, but it's getting there, but it's slower progress.
So what about pathology specific PRIs? You already showed some data for amyloid versus tau, considering these different pathways. Then cerebrovascular, I don't know how that was calculated. But because in our neuropath cohort, we're seeing all kinds of mostly amnestic AD type dementia patients, we're seeing all kinds of pathologies in addition to AD. Are there Lewy body specific risk scores, TDP-43 specific risk scores? What about is this data available so one could calculate?
Well, that I don't know, but that would be interesting then for you lot to look at from that perspective, because I wouldn't look at it from that viewpoint. But that's also the same issue with having these AD patients in the AD susceptibility, because some of them do have co-pathologies. But I think for both Kunkel and Berlingers, it's more of a pure AD phenotype. But in reality, how pure is that until you get to autopsy anyway?
Yeah.
So
we did this analysis.
No, exactly.
In the Rojas paper,
Yeah.
we had a subsample with neuropathology.
Yeah.
And many of the hits were correlated with non-AD traits in the neuropathology, like TDP-43. So some of these hits are not, because the phenotype is very poor. The clinical phenotype in this big cohort is really, really poor. And if you include the proxy cases, it's even worse.
Yeah.
So this is probably why they go for this muscle statistical, more power, not really
not super
granular
refined
phenotype, but big samples.
Yeah, I don't necessarily agree with that.
Right?
Mm-hmm.
So even you probably don't expect to get a perfect AD group, but if you get a group that you manage to enrich
at least enough,
and they are very big, even if the differences are very they are mixed, you will still see difference if you have thousands of hundreds of thousands of
exactly.
But for very common,
not if you don't report it though.
Hits that are related to synuclein and TDP-43 for sure in these big GWAS. So this is part of that.
Yeah, I mean, you see it in, I didn't put it on the screen, but you see it in the enrichment, in the biological process enrichment that you can do.
Where you discussed this, right? That you saw some hit and this was a gene that was very well known related with synuclein. I think
I think it was my RNA sequencing ADPD maybe or something. Yeah, if you can also do a similar kind of biological enrichment with sequencing data, RNA sequencing data, and that you rank your genes, and then you can input those. You can look at biological enrichment. So as you rank them, what pathways are most common in like different groups. And one of the genes was TMEM106B.
Yeah.
Oh my God, I can't believe I remember that too. That's from like 5 years ago. That was one of my top differentially expressed genes, actually.
And this is now related with TDP-43.
Yeah, exactly. So you see, even that was in FPAC. So FPAC is a sub cohort from Amipad. And I did the RNA expression for that. And that was one of my top differentially expressed genes. I think that was the only differentially expressed gene that was significant with amyloid accumulation over a longitudinal one.
Good memory.
Who knew I had that in me?
We have more questions?
Yeah, but also then on that note, before you ask, with other pathway enrichment I did with the RNA data, we see you can also do KEGG pathways. So looking at disease pathways, and it wasn't just Alzheimer's that came up, it was things like Parkinson's as well. So you do see a lot of overlap. That was with gene expression, not DNA based, but still similar vibes. Yeah. I mean, it's got such a high minor allele frequency anyway, like a quarter of the population have it.
Yeah, thank you. It's kind of funny because I'm actually looking at FTD, but my question actually has to do with the cell types. Because you said that you haven't been looking at like different cell populations yet.
No.
And I was wondering if you have any possible insights if I don't know, you have like anything to suspect because I'm very much interested in the whole neuroinflammation aspect of Alzheimer's disease and very much interested in microglia and things like that. So if you have like any insights of that, because that would be really interesting.
I have, the scores are being calculated right now. And one of the cell populations is microglia and astrocytes. So I am interested to see, I think there's astrocytes, microglia, oligodendrocyte precursor cells, and I think another one or two, but this is really just something we discussed last week. But I am interested to see the astrocytes and microglia distribution, let's say, in our cohort, but I can't tell you any more than that.
That's all right. Thank you. And great presentation.
Thank you. It's from a paper from 2023, I think, the cell types. Zhu et al, maybe? Like XU. I think. It's either 21, 2, or 3. I'm sure.
I don't know, but yeah, will be interesting.
Yeah, I agree.
Hi, I have a curiosity on the scheme and on the vision of the hierarchical screening process that you're thinking at, especially at what type of application. I mean, if it's very different if you say, okay, I want to do a hierarchical screening to do a clinical trial.
Mm-hmm.
So I need something that at the beginning picks
someone out, kind of. You mean?
There are no false positive.
Ah.
Right, so you just need, if you take 1 million people, I need 100 that are positive very early to do a clinical trial.
Mm-hmm.
So you maximize that side of the, or you say, okay, I'm a health system, and I want to give opportunity for a treatment I have for everybody who will, so I can I do not want to have false negative because I don't want to leave anybody outside. Where are you thinking in that trade-off for those type of
I think I would like to see it in a clinical trial scenario, because I think it's a bit closer to that point than in a general healthcare system way. And I think, but it's obviously not there yet in terms of false positive, false negatives. Like it wouldn't be anywhere near good enough. But I think it has the potential to pick out those people who are at the highest risk that could most benefit. But then also eventually, once we refine them a bit more, enable more of a direction with different treatments that could be available in a clinical trial scenario. And I think that's where there's the most potential rather than from a population-based healthcare system direction.
So then why first?
To pick out your risk? To
Yeah,
help refine your population for that trial?
But I mean, if you so you put it first because it's cheap.
But if it is, give the direction, but is not very specific in terms of, false positive and false negative.
Yeah, but not yet.
I think you cannot discuss this type of test as a false positive, false negative, because it's not a diagnostic test. It's a risk score, but it will be the same people that doesn't have the disease at all.
Yeah.
As far as I'm aware, she gave a very good example, that is the breast cancer. So
Yeah, there's the
this
CAD
course,
tool
if you
for
are
it.
in the risk group, you will be screened more often.
Yeah.
The disease. No, it's not the false positive, false negative, because you don't have you don't need to have the disease, just a risk score.
Yeah. That's when you could do some sort of primary risk assessment. Yeah, but that's different.
I think that's a good example in family, and because you may try to select individuals with an enriched family, and then do the PRS and see
where you sit on some sort of.
You have a higher
Yeah.
genetic risk load, and then do primary prevention in these individuals, or
Yeah.
follow them
Exactly.
for doing biomarkers in the future. When you have really preclinical and preclinical interventions ready for that.
Yeah, because it's not.
That's how I envision how
Me
we can use
too.
it in sort of primary prevention very early when plasma biomarkers are not in.
Exactly. Yeah, and then keep monitoring.
But excuse me, in relation to this discussion, imagine that you have identified the best PRS that you could imagine. And you select, according to this PRS, a cohort of people with high risk, with high PRS score, and very high risk of developing disease. And you try any preventive or any treatment, and you have success. The trial is positive.
Yeah.
To what extent these results, these positive results, this treatment that you have tried could be applied or extended to all the population, or only to those with high PRS score?
Well,
what then we could generalize something that we have found out in a selected high PRS score population.
I think the overall goal is to somehow refine different risk populations for different treatments, that eventually anyone can go to the clinic. What is their PRS risk profile? Then what is the best next step? Is it to then monitor them over the next 5 to 10 years of different plasma biomarkers? Is it to straight away do confirmatory PET or CSF analysis? Is it to direct them to 1 or 2 particular treatments, or a combination? I think that could maybe be how it's extended beyond just one trial scenario, but no single PRS is even as good as ApoE4 by itself right now. So I think a lot more refinement and maybe combinations need to be looked at in order to get to something closer to getting even started there. IBD is also a good field for that as well, with PRS. But I think it's because, well, the breast cancer and IBD field have been doing it for much longer than AD, so they're already a bit more advanced in where they're at. But then they've developed these kind of interactive tools. The CAMRIS tool is one for breast cancer, and then there's a new one for IBD, but I forgot the name. But like, you could go on a web interface, type in your different characteristics, and then look at recommendations and positive and negative predictive values. And I think that could be where we get to, but we're not there yet.
Thank you. It's a quick question. You said that you are going to try to understand better the result, but I am curious about if you have hypotheses related to the result that you show about the brain age and the ApoE4.
Oh, yeah.
Because it's,
You mean the one that was down here,
Yeah.
the non-ApoE brain age?
yeah. And if you have an hypothesis about that.
I have. Do you have a hypothesis?
No,
for that?
but when I saw the result, it's true that I remember that some studies show that ApoE for careers can show better or can outperform non-careers in early stages when, for example, in cognitively normal subjects. So maybe it could be related or not. I don't know.
I honestly don't know because I've not seen any result like that for any of my scores ever until I saw that one, and I'm a bit like, I need to look into it because I really don't know why. How old are they, the participants? Between 50 and 75, 80 at baseline. No. I think so, yeah. Yeah.
There have been some papers that have related very early amyloid accumulation with increases in volume. And
We were talking about this the other day.
And this could be interpreted by the algorithm as a younger brain.
Yeah, that's true, actually. Otherwise, I can't explain it. Yet.
Do we have more questions? Okay, so we are perfectly on time. Only 5
So
minutes.
British.
Only 5 minutes late. So we can give another.
It's acceptable.